Good afternoon, everybody. My name is Alkan. I'm glad I don't have to spell it. It's written. This is maybe the first time I don't have to spell my name. Today I have the privilege to present this unique case that I've seen last year. I had a 68-year-old man who came into the emergency room with a mainly left-sided pleuritic chest pain. That was started 1 week ago. He also had some shortness of breath and dry cough. The patient had no hemoptysis, no fever or chills. He had smoking history of 40. He had 40 pounds weight loss over the last 5 months. His past medical history was significant for hypertension, diabetes. He's morbid obese and has obstructive sleep apnea. He used his CPAP each night 4 to 6 hours. And also he had a chronic kidney disease with a baseline creatinine of 1.6. The patient also has retinopathy and neuropathy. He lives with his wife and he has an outside dog. He smoked 1 pack a day for 35 years, no alcohol, no IV drug abuse. On further questioning, he worked in a steel factory and he said that he had asbestos exposure. He worked for 10 years, he finished 1978. His outpatient medication is atenolol, diltiazem, furosemide, gabapentin, glyburide, hydrochlorothiazide, aspirin, lisinopril, and philodipine. I'll go quickly through the cases. Please stop me if anything before we go to physical exam. If anything that want to ask about HPI, I will be ready to just stop me or raise your hand, guys. I can stop. It should be like interactive between each other. On physical examination, his vital signs were fairly okay. Blood pressure, 150/75, heart rate 72. His temperature was normal, and he was breathing 18 times a minute. His oxygen saturation appears to be 82% on room air, which looks like chronic, something has been going on for a while. On further examination, his chest showed basilar bronchitis, no wheezing, there was no crackles. His belly was normal other than obesity. And in extremities he had +2 edema. The patient also has decreased sensation in the lower extremity from his neuropathy. Initial CBC Chem7. Fairly, his Chem7 looks normal except for his creatinine at his baseline. And he had leukocytosis with mostly neutrophil. His BNP was normal according to our lab, and his initial blood gases that was done on 50% face mask, venti mask, 50%, showed pH 7.39, PCO2 37, PO2 67 on 50%. And we looked at the back all chest X-ray, which was normal 7 months ago. And the first thing when we did physical examination, we went and we did the chest X-ray that was done in the emergency room.
And this might be a good time to stop now and let Dr. Henson-Flash take a look at this radiograph and maybe share with us his interpretation of the radiograph as well as some thoughts at this point in the case.
Ask me any question about the case. I went through it very quickly, sorry.
Here we go. Thank you. All right, well, first, thanks for the privilege of being here today and for doing this. I love this part of pulmonary medicine. I have an opportunity to recruit and speak with a lot of fellows applying for programs in our program, and I always tell them one of the things that I like most about pulmonary medicine is it's such a magnificent diagnostic field. The chest X-ray is a window to the whole body, window to the soul. So many diseases set foot in the thorax in some way or another, at some time or another. somebody really interested in diagnostic medicine is well served by choosing our specialty. It's also very, very humbling. I have set out to learn all of the diseases that set foot in the chest in my lifetime, and I absolutely positively am not there yet. I'm still identifying 1, 2, 3 diseases that are relevant to chest medicine that I never knew of before. So my own learning curve continues to be very steep. And of course, if it sounds like I'm saying all this to let up a set of excuses, you're exactly right on target. So please, let's identify all of us as the stars today. Certainly not me and Travis, but all the people in the room, and let's work ourselves together through these cases and see if we can hit the curveballs and the fastballs and the sliders that are coming out of these two wise guy presenters. Let's just take a look at the chest x-ray first. I'm at a bad angle, but I did have a quick look at it. That's a top, a normal-sized heart, and I'm looking below the diaphragm and not able to pick up evidence of hepatosplenomegaly, something I would look for there, or an obvious abnormality in the mediastinum, or in the soft tissues of the shoulder. So we'll focus in on the lungs, which are obviously and dramatically abnormal with a profusion of nodules. They're clearly nodular with some fuzzy borders. They don't silhouette the heart border or very much the diaphragms, and seem to be about equally distributed in this AP view or PA view from center to periphery and from apex to base. So we're looking at nodules in a person who's come into the emergency room with shortness of breath, dry cough, no fever. Very importantly, a 40-pound weight loss over several months on a backdrop of diabetes, obesity, obstructive sleep apnea, complications of those diseases. And then one of the curveballs here perhaps is a history of this man being a steel worker and having some exposure to asbestos. He's on several medications, including 1 or 2 that might every once in a while have relevance to the chest, hydrochlorothiazide perhaps, and aspirin. Differential diagnosis of nodules in this setting. First, can we have a quick home run by connecting this x-ray to something in his past medical history? And I'll comment on asbestos. In our practice here in Philadelphia, home of very major naval shipyard during World War II, we see a fair amount of asbestos-related chest abnormalities, most of which will present to us in 2 forms now: pleural disease, pleural space disease, and malignancy. We've seen cases of asbestosis, but pulmonary parenchymal disease that we can confidently identify at this stage is uncommon, I think, reflecting the lower exposures to asbestos in the later years of continued asbestos exposure in our neck of the woods. And this is not at all how asbestosis looks in the chest. Peripheral reticular pattern. This is nodules. So I think I could set that aside, and I'm not ringing any quick bells with the history of his non-thoracic comorbidities at this point. So let's throw a broad net to begin with and hope that we have a little bit more information to narrow it down. Starting thinking about infectious diseases. We don't have a precise handle yet on how many days of shortness of breath and dry cough, but I'm assuming this is a few days. How long for the chest symptoms?
It was merely for over many months since he has
the chest, okay.
shortness of breath
So
and dry cough.
a subacute progression of shortness of